what was then known as Bacillus mallei. And this was a disease of horses where there would be respiratory symptoms, or in this case, draining lymph nodes with pus that could be transferred to humans. But they were perplexed in this case because their individuals who were morphine addicts didn't have clear exposure to horses. And when they looked at the lungs pathologically, and this is a rendering by a local artist, they found these cheesy consolidations within the lung that was a little uncharacteristic compared to what they were used to seeing with glanders. And they isolated a bacillus from these autopsies, and they were surprised because the bacteria grew more rapidly and more luxuriantly than they expected for B. mallei. And it was also motile in early culture, in contrast to Bacillus mallei. In addition, the infection of guinea pigs with this newly found organism did not seem to cause the typical inflammation of guinea pig testicles that was used diagnostically to identify B. mallei. This is the Strauss reaction. And that was in large part due to the fact that the guinea pigs didn't survive long enough to have testicular inflammation when infected with the organisms that they got from these patients' lungs. And so this was this organism they called Bacillus pseudomallei, to distinguish it from mallei, but also acknowledge some of the similarities. And it was a gram-negative organism, sometimes with some bipolar staining on, as hard to see in this little arrow here, but that was occasionally seen. Now, subsequently, a little bit further south here, in Kuala Lumpur, Stanton and Fletcher were investigators in an animal research facility there, and they noticed a devastating infection that was sweeping through their facility, and they found that this appeared to be the Bacillus pseudomallei, causing what was then known as Whitmore's disease, and they actually coined the term melioidosis, which melis for distemper of asses, and eidos for similar to, and this was therefore melioidosis, again marking its similarity to glanders. And over the years then, the organism and the infection has been found throughout Southeast Asia, more widely in Asia, then in Australia, where it became recognized as a veterinary pathogen in particular. And then quite a bit of attention was drawn to the disease during the Vietnam conflict, as service members became infected with this unusual disease, sometimes quite some time after their exposure in the theater. And this disease, melioidosis, was also featured in a Sherlock Holmes story by Arthur Conan Doyle, The Adventure of the Dying Detective, which Doyle called it Tapanuli fever, and Holmes was allegedly infected with it. Of course, he actually wasn't, and he prevailed ultimately, in contrast to many of the patients who were actually infected with it in reality. Now, the infection was also brought to popular attention in Paris in the 70s, when the affaire du Jardin des Plantes occurred. And as you can see, this caused headlines in a variety of newspapers. And what occurred was there was a die-off of animals in this small zoo, the Jardin des Plantes in Paris. A horse, a deer, monkey, pigeon, rat, sheep, oryx, all were died, and the Bacille de Whitmore, the B. pseudomallei, which subsequently has become known as Burkholderia pseudomallei, instead of bacillus, was isolated from these animals. And the question was, well, where did this come from? This had not been previously reported in France. And it turned out that at a neighboring zoo in Paris, in the preceding year and a half or so, several other animals had died of somewhat mysterious circumstances. And they'd been autopsied, but they hadn't actually had any cultures taken. But many of them were now in the fridge. I can't really imagine their condition, but they were culturable, and a panda, a gazelle, and a chimpanzee all had evidence of B. pseudomallei on culture. And this panda was of particular interest because Georges Pompidou, Prime Minister originally of France and at this time period in the early 70s, President of France, had visited Mao in China and was offered as a gift 2 pandas, Lili and Yen Yen, who were shipped to France, to this more major zoo, not to the Jardin des Plantes. And this is, in fact, one of those pandas, although I'm not sure which one. And these pandas were supposed to be a pair, a couple, a male and a female, although subsequently it turned out they were both male, apparently. But one of these 2 pandas was the panda that was in the fridge that was culture positive for B. pseudomallei. And this is that panda in less happy times on the autopsy tape. Subsequently, that outbreak seemed to wane. In fact, there was, for a period, dissemination of the organism, it seems, throughout France, to other stables, to horses, and contamination of soil. It was isolated from the soil in the Jardin des Plantes, and then there seemed to be spread throughout the region. But ultimately, then, it all seemed to go away, and there were not more cases of melioidosis described in France subsequently. And really now we think about B. pseudomallei and melioidosis as a particular problem in Southeast Asia. And the organism, you know, is a soil saprophyte. So it lives in wet soil in the tropics. And this is a picture of a rice farmer in northeast Thailand who is probably in a rice paddy here that is jam-packed full of Burkholderia pseudomallei. And there have been quite extensive environmental studies done in recent years to characterize the distribution of the organism throughout the areas. But essentially, exposure occurs in individuals who are in this environment. It's also, as I've mentioned, a veterinary pathogen, and an important veterinary pathogen in Australia, where there have been outbreaks in piggeries and so forth, as well as an important human pathogen in Australia, which we will get to here in a moment. But in northeast Thailand, this region here, this is the Asan region of Thailand. I would point out that it is a long distance away from Phuket and beaches and so forth down here in the south in the Gulf of Thailand. And this is a very arid and actually Thailand's poorest region. And this hospital, Sappasithiprasong Hospital, is where much of the clinical research on melioidosis has actually taken place. And so at this hospital, 400 culture-proven cases of melioidosis are diagnosed per year. A really quite staggering number. And in the region, that calculates out to an incidence of about 21 per 100,000 population. And so this whole northeast area of Thailand is a hotspot for B. pseudomallei infection, for melioidosis. I mentioned Australia, and of course the top end of Australia here is also pretty tropical. And the second site where a large number of cases have been described clinically is the Royal Darwin Hospital, where they've now reported on over 600 cases in the past couple of decades. They report a similar incidence to northeast Thailand, but the population in the top end of Australia is a lot less than in northeast Thailand, so the absolute number of cases is lower. Their incidence, however, is some 5-fold higher in indigenous populations in and around Darwin. And interestingly, they had a couple of years ago a very wet season, and they identified 93 cases in 1 year, which was several-fold increased over what they normally identify on an annual basis. But these two sites in northeast Thailand and in Darwin, Australia, have provided an awful lot of the clinical, the epidemiologic data, and being the sites of clinical trials that have informed our understanding of and treatment of melioidosis. Now, interestingly, for individuals who live in these areas, there is quite variable seropositivity. Now, in northeast Thailand, if you assay antibody titers, you'll see that in children who are, by the time they get to about age 5, there's a pretty high rate of detectable antibody titer, over 50%, that persists throughout childhood and on. So this suggests that a lot of individuals are exposed due to their proximity to the organism in the environment, although, of course, not everybody develops disease. In Northern Australia, interestingly, the seropositive rate is much lower, both in northern Queensland, where it's more in the 5 to 6% rate, and in studies in Darwin. And that's not really very well understood. But perhaps it reflects some differences in exposure to the organism. Now, clinical infection occurs, it's thought, by one of 3 primary routes. The first is inhalation, and there's good evidence in support of this in humans. For example, helicopter pilots during the Vietnam War who did not actually spend time down on the ground seem to have a higher rate of contracting the infection than others. Also, when it's very windy and rainy, the rates of pneumonia cases increase. Second route of infection that's deemed very common, perhaps more common than inhalation, is cutaneous inoculation. And so if you're in the environment, as many rice farmers, for example, are, or indigenous peoples in northern Australia, where you may not be wearing footwear, or if you are, you may have cuts and so forth, there's an opportunity for the organism to enter through the skin and cause infection that way. And a third route of infection is ingestion, where consuming contaminated water, potentially swimming and consuming water, or drinking water that's contaminated can result in infection. And then the range of infection that results is quite astounding. First of all, it's usually not clear which particular route of infection occurred in most patients. Most infection is quite acute. The exposure to the environment occurred quite recently, and infection is fairly dramatic. People are sick. They have pneumonia, they have sepsis. Now, there can be abscess formation, though, in the liver, in the spleens, in the prostate. There can be bone involvement. There can be joint involvement, skin. In a subset of cases, there is a more chronic form of infection, where individuals are exposed, they get infected, and they have a sort of a more lingering, less fulminant course. And then there are cases when there appears to be a tremendously long latent period, and the longest to date being some 60 years between exposure to a contaminated environment and development of symptoms, suggesting that there may be some sort of reactivation phenomenon that also occurs, a little akin to tuberculosis. So it's really quite fascinating, all these different clinical manifestations. Now, in 50% of cases, in 50% of cases, the lungs are involved. And so this is a representative example of consolidation of the right lung, and here you see an abscess in this left lung, and that is quite a common appearance. In patients who have more chronic type disease, there can be a lot of overlap with the clinical symptoms of tuberculosis, and radiographic appearance can be very similar as well. Many patients who are treated presumptively or empirically for tuberculosis in these regions are at risk and may potentially have melioidosis as well. So it's been known as the great mimicker because of this wealth of clinical manifestations, and really, all bets are off with this. It can present in such a wide range of manners. You can't really exclude any type of clinical presentation. Now, what are some of the clinical risk factors for disease? Well, these have been fairly well characterized, again, with data from Northeast Thailand, from Northern Australia, and really, you can see here diabetes, renal disease, chronic lung disease, older age, male sex, alcohol abuse, sort of risk factors that you might expect that would impair your immunity and predispose you to infection. Notably, HIV is not a risk factor for melioidosis in studies to date. And I would draw your attention here to these incidence rates of in individuals without diabetes and in individuals with diabetes. And so the incidence per 100,000 population here without diabetes is just under 7. If you've got diabetes, the incidence is 145. So a whopping risk attributable to diabetes for reasons that frankly are not very well understood to date. Melioidosis, I've talked a lot just over the last few minutes about Northeast Thailand and Northern Australia, but let me also explain that this disease is a tropical pathogen. And I just summarize here the reports in the literature, the number of cases reported in the literature in some other Southeast Asian studies. And so what we have here is 50 up in Hanoi, 409 in Laos, 145 down here in Malaysia, 693 in Singapore, 100 in Cambodia. Now, before 2008, there were no cases reported in Cambodia, and already in the last few years, in a quick PubMed search, there's over 100 cases reported. The point is here that I think the more you look in many tropical regions, the more you're likely to find, and that definitely seems to have been the case in Cambodia. This is a nice map of the global distribution of B. pseudomallei in the environment put together by one of my colleagues at Nahidon University, which shows the definite environmental contamination here in red. And then you can see this band going across the tropics, stretching from Asia to Africa and to the Americas, where there appears to be evidence of Burkholderia in the environment, Burkholderia pseudomallei in the environment, and there are these indigenous cases that are being reported really now on a weekly basis that pop up in a number of different places, and Madagascar is another hot spot for melioidosis. So here's the organism Burkholderia pseudomallei growing on selective media, and when you look more closely, you realize that there are a variety of different morphologies of this organism. These are 6 different morphologies, and here's the an electron micrograph showing the organism. And in 2004, the organism was sequenced, and it's got a large genome with 2 chromosomes. And I'll point out that so a large genome with a variety of morphologies. these morphologies, these particular colonies, were actually isolated from B. pseudomallei that was cultured from a tube of water that one of my colleagues in Mahidol University inoculated, distilled water, inoculated 16 years ago, and was just left with the tube top cracked ever so slightly, adds distilled water every few years, and every 5 years or so goes in and cultures B. pseudomallei from this distilled water. And it's detectable. It is a hardy organism that is able to survive without really nutrients or much else in this distilled water for decades, and yet has this morphologic variability, probably in part due to this large chromosome. So it's quite a remarkable pathogen. It's an intracellular pathogen, we now know, and hopefully I can show you. This is not actually B. pseudomallei. This is a very closely related organism called Burkholderia thailandensis that actually exists in the soil along with B. pseudomallei. It differs by its assimilation of arabinose, and it doesn't cause infection in humans the way B. pseudomallei does. But it's very similar in many respects, and so it's used as a surrogate research organism. Let me show you here these HEK cells that are infected with B. thailandensis. And this bacteria is being clocked at 25 micrometers per second. And you can see here it's just zipping around these cells in and out with what I would describe as gay abandon. And in fact, the organism infects a whole host of different cells, phagocytes, non-phagocytic cells. It gets in, it pops out of the endosome in a type 3 secretion system mediated fashion, and then it runs amok. And it hijacks the actin machinery in the cell, it uses flagella of its own, and it brings cells together, it induces cell-to-cell fusion, and creates multinucleated giant cells that are then seen histologically. So it's a facultative intracellular pathogen that really, I think that previous video says it all. It seems to be quite uninhibited. It's also a very resistant pathogen to antimicrobial therapy. And this cartoon shows a bacterial cell here, courtesy of Herb Schweitzer at Colorado State University, and some of the potential mechanisms of bacterial resistance. And many of these have been described for B. pseudomallei, with resulting effects on antimicrobial sensitivity. The LPS of B. pseudomallei seems to facilitate exclusion of some antibiotics from the cell, including polymyxin. Efflux pumps play a major role in B. pseudomallei resistance, including resistance to aminoglycosides, to macrolides, to fluoroquinolones, to tetracyclines, to chloramphenicol, trimethoprim without sulfamethoxazole. Enzymatic inactivation, in this case beta-lactamase that cleaves the beta-lactam, results in resistance of B. pseudomallei to penicillins, to first generation, to second generation, and to many third generation cephalosporins. And also with some mutations in this beta-lactamase, which is a PEN-A beta-lactamase, there's ceftazidime resistance, and then another form of ceftazidime resistance is actually deletion of penicillin binding protein site, causing causing ceftazidime resistance. So there's a variety of mechanisms of antimicrobial resistance, and ultimately the organism is really susceptible to very few agents. The treatment of choice currently is ceftazidime, although, as I pointed out on the previous slide, ceftazidime resistance has been reported. Other options include imipenem or meropenem, and I'm not aware of carbapenem resistance having been reported to date. The use of, so these have been compared in head-to-head clinical trials, and ceftazidime actually in the late 80s was selected as the treatment of choice for melioidosis on the basis of a large randomized trial that was conducted in which the mortality rate was 80% for patients treated with a chloramphenicol, doxycycline, and some other medication concoction versus ceftazidime, where the mortality rate dropped substantially, 40%. So currently, the treatment recommendations for this very resistant organism are 2 weeks of intravenous therapy with ceftazidime, or if there are concerns about resistance or failure to respond to ceftazidime, then the use of a carbapenem, and meropenem is what's frequently chosen in the hotspots where it's available. But then you have to follow that therapy with an eradication phase of up to 6 months of trimethoprim sulfamethoxazole orally. And we know that clinically patients take quite some time to recover from their infection. Their fever curve takes a long time to break. They are monitored then basically monthly or so throughout this long trimethoprim sulfa course. And despite this, in northeast Thailand, 40% of these patients die. So that really hasn't changed in the past since the study showing ceftazidime, which was in 1989. So that really hasn't changed in a couple of decades dramatically. And of the survivors, some 15% have recurrent infection. 10% have relapse, and 5% actually get reinfected with a different organism. This is based on molecular typing. The outcomes are somewhat better in northern Australia and Malaysia, Singapore, and so forth. And there may be a variety of different factors explaining that, but one of them is probably the intensity of care, the availability of ICUs that are less accessible in northeast Thailand. So outcomes are pretty grim from this infection, despite choosing the optimal antibiotics. And you can see the treatment is no walk in the park. It's a 6-month ordeal. In some cases, you can get away with non-IV therapy for localized skin infection, but you have to be very careful because these patients will often have systemic hidden foci that have resulted in this very aggressive regimen being promulgated that I just described. So melioidosis is a leading infectious cause of death in northeast Thailand, and you can see here epidemiologic data from my colleague Derek Limathorotsical at Mahidol University shows that in terms of mortality rate per 100,000 population, here's AIDS, and here's TB, and here's melioidosis, tied for second in 2006, a little lower previously. This is a major killer in this region. Now, because the organism is so resistant to various antibiotics, because it can be aerosolized, and it's quite easy to get infected with it, theoretically, because treatment is complex, because the outcomes are severe, are poor, this organism has been labeled a Tier 1 select agent by the U.S. government. B. pseudomallei is classified as a select agent, a pathogen of concern, essentially by both HHS and the USDA, because it's a human and a veterinary pathogen. What are some other Tier 1 select agents that keep Burkholderia pseudomallei company? Ebola, smallpox, anthrax, plague. So this is considered a major biothreat by the U.S. government. It hasn't actually been weaponized, but there has been an influx of money into Burkholderia pseudomallei research in recent years, which has benefited the patients in the tropics for whom it is an active everyday public health threat. So with that bit of background, let me move on to some of the work that our group has been focusing on in recent years. There are obviously many challenges to address with melioidosis, and we've focused really on host susceptibility and mechanisms of host defense, in the hope that understanding the host response to this gram-negative and flagellated pathogen may actually be useful not only in finding new therapies to this resistant organism, but also perhaps being useful for other causes of pneumonia and sepsis. And so we focus primarily on pathogen recognition receptor signaling. And so pathogen recognition receptors include membrane-bound and cytoplasmic receptors that are part of the innate immune system that recognize conserved motifs on pathogens and some endogenous motifs as well, and they result then in an inflammatory response. This is all innate. It does not require any priming or any acquired immunity to exist. And membrane-bound receptors include the toll-like receptors, and in this case, these receptors are shown here on the plasma membrane of a macrophage. Toll-like receptor 2 recognizes lipopeptides in the bacterial cell wall. Toll-like receptor 4 recognizes lipopolysaccharide, the endotoxin of gram-negative bacteria, and toll-like receptor 5 recognizes flagellin. And Burkholderia theoretically should trigger all of these. And these then result in translocation of transcription factors such as NF-kappa B into the nucleus, and then the induction of cytokine, production of cytokines and resultant inflammatory responses. And there are several cytoplasmic pathogen recognition receptors as well that are also of interest. Nods here are cytoplasmic receptors that also recognize components of the cell wall and again result in NF-kappa B activation and cytokine production. And then there are nod-like receptors that form this platform within the cytoplasm of the cell known as the inflammasome, and this is usually a caspase-1 dependent process. The formation of this inflammasome upon recognition of specific bacterial elements results in caspase-1 cleaving off the pro form of interleukin 1 beta and IL-18 to their active forms, and with resultant inflammation. So there's this triad of pathogen recognition receptors that have been of interest to us. And when I first started working on this with Sean Skerritt in Pulmonary, we developed a murine model of infection with B. pseudomallei. And so this is a mouse that is exposed to an aerosol of B. pseudomallei. The mouse develops a respiratory infection that can disseminate beyond the lungs, below the diaphragm, to liver, spleen, and elsewhere. And this is a useful model for study of survival, for study of inflammation, and trying to tease out what elements of the host response are important. And what I show you here is some survival curves, or survival lines really, from infection of mice with a variety of different inoculating doses of Burkholderia pseudomallei. And the take-home point is that low doses of B. pseudomallei in our hands deposited in the lungs do not necessarily cause lethal infection, but once you get up to 300 or higher CFUs per lung, you start to see mortality that is pretty rapid. And there is, in terms of bacterial replication, there is evidence, even at non-lethal infecting doses, of replication in the lungs early after infection and dissemination to the liver and spleen. This organism goes to the lungs and then goes out through the bloodstream and to beyond and beyond. But in mice that survive, this is controlled and diminishes over time. Similarly, there's inflammation in the lungs. that is more apparent at day 1. It's a neutrophil predominant inflammatory process. Over time, as the mice control the infection, there's more of a mononuclear predominance. This is in the bronchoalveolar lavage fluid of the infected mice. And histologically, there is evidence of, this is at day 1 and this is at day 4. After infection, there's evidence of scattered foci of inflammation consistent with our lavage data. So we've found that several pathogen recognition receptors are important in facilitating host defense to respiratory melioidosis in the mouse. Toll-like receptor 5, as I mentioned, this is the receptor for flagellin. If you knock that out and you assess survival, you see that the toll-like receptor 5 mice die sooner. We've also looked at this in relation to NLRC4. NLRC4 is one of the receptors, or at least one of the proteins that's within the inflammasome complex that I mentioned to you. And NLRC4, along with another protein called NAPE, recognize flagellin in the cell, whereas TLR5 is on the cell membrane. In the cytoplasm, NLRC4 plus NAPE recognize flagellin. And so we found that NLRC4 deficiency also results in earlier mortality of mice. But when you delete both TLR5 and NLRC4, you don't see any added effect, at least looking at survival as a readout. NOD2, we've also found a more modest phenotype on survival when you don't have it, but there is increased bacterial replication and dissemination in mice that don't have that cytoplasmic receptor. So these are just some examples of our murine studies that have permitted us to examine roles of specific toll-like receptors and cytoplasmic receptors, such as these nods and nod-like receptors. But obviously mice are not humans. And so in more recent years, we've been working on trying to understand the human response. And again, with the goal of identifying potential targets for therapeutic intervention in the long term. And we know from work by Mark Werfel in pulmonary and critical care medicine, and that we've then repeated, that there is substantial inter-host variation in the innate immune response. And so this is TNF-alpha on a log scale, and this is, on the x-axis here, a large number, a range of different innate immune stimuli. Stimulate TOL2, TOL5, TOL4, as well as heat-killed bacteria, Burkholderia and staph. And what we've done here, following Mark's model, is essentially we took 300 healthy Thai folks and we stimulated their blood with these different ligands, and we measured TNF-alpha. And the point is that there's tremendous variability from person to person, really covering almost 2 logs for nearly all of these stimuli. And so that tells you that people are you knew this, but people are different. And with respect to their innate immune systems as well. And we've decided to pursue a genetic strategy to understanding susceptibility to melioidosis, in part based on this seminal paper from the late 80s, Sorensen and the Danish adoptees study. And so this was a study in which adoptees were followed, and if they died, it was possible to ascertain the effect of death of a biologic or adoptive parent on the adoptee mortality. So what this shows is that for individuals who died of infection, the relative risk of death was much greater if your biologic parent had died prematurely from infection in comparison to death of your adoptive parent from infection. So this meant that there was something about your parent dying early from infection that increased your risk of dying early from infection and suggested that there's a genetic underpinning to your susceptibility to infection. And now subsequent studies looking at genetic variation and association with outcomes have confirmed that. In a variety of different diseases, we decided to try to look at this in melioidosis. And so Sappasithiprasong Hospital in Ubon Ratchathani in the northeast of Thailand there, right near the Lao and Cambodia borders, has been the site of many of our studies, and this work has all been done in conjunction with the melioidosis study team there, the Mahidol University and Wellcome Trust-funded Oxford Tropical Research Unit have been fantastic partners. This is where 400 cases of melioidosis are diagnosed every year. It's really the only place in the world presently where it's feasible to do clinical research that requires large numbers of patients. And we looked at some of these same innate immune genes that we described in mice. And so one of them is toll-like receptor 5. And toll-like receptor 5 is the flagellin receptor that sits on the cell membrane. And Tom Hahn, in Allergy and Infectious Diseases here, just over 10 years, described a quite remarkable polymorphism in TLR5 that is a nonsense mutation. It changes an arginine to a stop codon, and it prematurely truncates the receptor. So normally TLR5 has an exterior transmembrane and a cytoplasmic elements, and this mutation is predicted to truncate it, so there's no transmembrane or cytoplasmic domains. And Tom has shown that there is abrogation of signaling in response to flagellin in carriers of this mutation, and we have confirmed that. This is simply data where we have transfected this DNA, it's either wild type or this mutant, into HEK cells, human embryonic kidney cells, in order to essentially ascertain what sort of inflammatory response there is in this very simple model. So we transfect the DNA, the cell expresses that wild type or mutant TLR5, and we stimulate with flagellin or with Burkholderia, and you can see here that the mutant here has markedly abrogated activation of, in this case, NF-kappa B, the transcription factor, suggesting that it is non-functional. Now, when you look in melioidosis patients, there is also a very significant effect of carriage of this receptor. Well, it's an association. We can't say it's causative. And so this is survival after melioidosis. And up here are carriers of the mutant allele on TLR5, and down here are wild-type individuals. And when you actually plot out the survival, you see that of those who survived, a much higher proportion carried the T allele compared to those who died, 15-ish% versus 4%. So the odds ratio of survival is actually 5-fold greater if you happen to have this mutation and altered flagellin signaling. And that's a pretty sizable odds ratio that got us really quite interested. So what we did next was we have set up a research program in Seattle where we've recruited Southeast Asian subjects who are healthy for, we're genotyping them and we're recalling them for blood draws or for bronchoscopy. And I'm going to focus here on some of our recent work on the lung cells because, as I mentioned, 50% of melioid cases involve the lung. We're quite interested in how the lung cells respond to B pseudomallei and whether this TLR5 polymorphism that we've seen this association with survival could maybe be explained by the lung cell response. So we perform bronchoscopy in healthy subjects. We've recruited about 200 individuals. We haven't done 200 bronchoscopies. We've done more like half a dozen bronchoscopies to obtain primary human alveolar macrophages. And what we've managed to do thus far has been infect these alveolar macrophages with B thailandensis and show that, that the organism infects the cell, it survives intracellularly, although over 6 hours it certainly doesn't grow, but it doesn't necessarily die off. These are just 3 different subjects, 2 hours and 6 hours, looking at the CFU of bacteria in alveolar macrophages. And we've done something similar with an attenuated mutant of B. pseudomallei. This is a B. pseudomallei that we can use outside of a high containment lab that is required for the virulent pathogen. This organism requires adenine and thymine, this mutant, to survive, and it probably doesn't get that in the cell, but the point here is that we've managed to infect these alveolar macrophages with B. pseudomallei, suggesting that there may be a role for TLR5 well, this doesn't specifically suggest a role for TLR5, but it shows that B. pseudomallei, not surprisingly, infects alveolar macrophages, and that it allows us then to study the role of TLR5. We know that these alveolar macrophages respond to increasing doses of flagellin, and our next steps now are to recruit back individuals who either have this polymorphism or don't, to try to compare how B. pseudomallei replicates in the alveolar macrophage and what the inflammatory response that results is. So this is really just fairly hot off the press data, just showing that we're beginning to look in alveolar macrophages in humans, which has not been studied for B. pseudomallei at all, and I hope will be fruitful. Some additional information that we've, additional data that we've generated recently has been to look at B. pseudomallei LPS and understand the LPS TLR4 axis. Many people know that LPS is the TLR4 agonist, and so in a way this isn't very surprising, but there have been some early publications that argue that LPS from B. pseudomallei is actually not a TLR4 agonist. I won't necessarily go through all of these in gory detail, but suffice it to say that we've shown that B. pseudomallei LPS is a TLR4 agonist when in cells transfected with TLR4 and stimulated with LPS, and also in murine macrophages that have TLR4 knocked out. We've seen that the effect is LPS, the effective LPS-induced cytokine production is dependent on TLR4. So we feel confident saying that B. pseudomallei LPS is a TLR4 agonist, and it's as inflammatory as LPS is from other bacteria. Again, there's old literature saying, well, B. pseudomallei is a very serious pathogen, but its LPS is a little bit funky. It doesn't recognize TLR4, it's not recognized by TLR4, and it's not very inflammatory, which is not unheard of with some gram-negative pathogens, but given the similarity of B. pseudomallei to Pseudomonas, struck us as a little bit odd. And we've in fact shown that now that B. pseudomallei LPS does seem to produce the same sort of inflammatory cytokine response in healthy humans as in other, as does LPS of other bacteria. We've also found that B. pseudomallei LPS seems to drive the cytokine response to whole Burkholderia pseudomallei, further emphasizing the importance of LPS. And what we've got here is simply a correlation matrix. This is blood of healthy donors from northeast Thailand stimulated with B. pseudomallei killed or LPS, and basically white and yellow is highly correlated. And you can see here that this is B. pseudomallei, these two different strains of killed B. pseudomallei. The TNF-alpha response is very highly correlated with LPS responses, E. coli, staph, and B. pseudomallei. And if you block the LPS TLR4 axis, either by using polymyxin or by using a TLR4 blocking antibody, you get a marked decrement in TNF-alpha. So on the x-axis here is TNF-alpha units. Here we have the human monocyte response to B. pseudomallei. You block with polymyxin, the TNF response is greatly reduced. You block with the TLR4 specific antibody, it's greatly reduced. So again, this seems to support an important role for LPS, the LPS TLR4 axis in human response to Burkholderia. And we've also shown that genetic variation in TLR4, both coding and non-coding variation, is associated with melioidosis. Finally, we've been excited by these candidate gene approaches, these looking at specific receptors and trying to tease out what some of the effects are. But we're also interested more broadly in determinants of outcome in melioidosis. And so we've also pursued in recent years whole exome sequencing of individuals with very extreme phenotypes of melioidosis to try to identify other, as of yet, undetermined genetic elements here. The notion here is that we do whole exome sequencing, so not whole genome, but just focusing on the exons and the exome in a fairly small number of patients. This is budget limited due to the cost of whole exome sequencing, although it's been coming down. And we try to inflate our odds ratios of effect by choosing either very mild patients or very fulminant patients. So really people at the extremes of the curve with respect to phenotype. And we're doing analysis there. Bottom line here is that we've got about 99,000 variants that are all coding variants in the exons, and we cover about 13,500 genes. And so we're currently working on this. I'll show you this one example that we've found that's exciting. This is a gene POLR3F that we found variation in only in individuals with the mild phenotype, not in individuals with the fulminant phenotype. And this gene encodes a subunit of RNA polymerase 3, which is involved in sensing and in limiting infection by intracellular bacteria. So we're very excited to try to validate this, see whether this association may be real, and if it is, then understand a little bit more, hopefully, about mechanisms afoot in melioidosis. So to conclude here, melioidosis is a complex and severe disease, but it's caused by a quite unique and remarkable pathogen, Burkholderia pseudomallei. I think the global burden of melioidosis is probably a lot greater than what's currently recognized. The pattern seems to have been in tropical areas, particularly in Southeast Asia. The more you look, the more you tend to find. And there are a lot of areas where there's very limited diagnostic microbiology capacity. And as shown in Cambodia, as that expands, even over the space of a few years, it has profound effects on really what are the antibiotics clinicians are reaching for, on what is being put on the essential medicines list, and so forth. So I think there's probably more melioid out there than we realize, and it's important to identify because it's difficult to treat, because it's so lethal. And along those lines, we need a better understanding of host susceptibility to infection, what drives outcomes from infection in this disease, such that we can identify new therapeutic options that may be useful not only for melioid, but also for other causes of pneumonia and sepsis with lung. So I'll stop here. I'll acknowledge a whole host of collaborators. My lab group here, who've been really instrumental in generating all of this work. Some added help from Amy Dickey, formerly of the medicine residency program, and our medical students. My mentor, Sean Skerritt, Tom Hawn in infectious diseases, Mark Werfel, Mary Emond in biostatistics, and Denny Liggett, and then ongoing collaborations with all of these folks. Tony Hahn and Lauren Kinman run the BSL-3 select agent lab that we have done a lot of the work in. And at Maridown University, my collaborators there are Marissa Chantrotita, Dirk Lemathuropsical, Sharon Peacock in particular, and these are absolutely fantastic folks who have been pushing melioidosis research forward in an unparalleled manner. So I'll stop there and take any questions. Thank you.
When you showed 1 in 5,000 people in these endemic regions get the disease every year, which is huge. Prospects for immunization?
Yes, I didn't touch on vaccination, but there are efforts underway, and thus far they've been pretty uniformly unsuccessful. There have also been efforts to try to decrease exposure by getting people, particularly diabetics, to wear boots and masks and so forth, that have also been similarly unsuccessful. The answer to your question is yes, there are efforts to develop vaccines, but thus far nothing productive has been identified.
Owen, has your work found any reason for the association initially with morphine and the addiction, the addict?
Oh, well, I wonder whether what has actually happened with those addicts was that they were injecting some water that was contaminated. All of these were injectors. And plus I suspect they were perhaps somewhat down and out, not the most robust individuals, and therefore at greater risk because of the association of chronic disease. I don't think there's anything specific about the morphine beyond those. Yes, and so the most famous case was a 60-year period between exposure and onset of disease, and I think that does occur. It's hard to know how much that actually that actually plays into day-to-day melioidosis. I think it does occur, but because you can also get it very acutely, it's really quite difficult to tease out. I've been struck by the number of patients, for example, in Sappasithiprasong Hospital, who come in from, say, trauma, and maybe they were thrown into a ditch, and they come in with polytrauma, they're managed, and 24 hours later they get febrile and they have blood cultures drawn and they're positive for pseudomallei. And so there the question for me is, are these individuals are they aspirating when they're thrown into a ditch and they're aspirating contaminated water? Or are these individuals who had latent infection, who get severely ill, have a profound alteration in their immune response, and they reactivate? We don't know.
Thank you very much.
Thank you.